Well, greetings from sunny Florida. This is Dr. Michael A. Picos, and my topic for you is minimally invasive crestal sinus augmentation, evolving concepts and techniques. A very interesting and I think timely one. And during this time frame together, I would like to share with you some of my clinical experiences with this particular evolving protocol. So first things first, I'm fortunate to be in practice now for some 37 years. I have a wonderful team of clinicians with me at Coastal Jaw Surgery. We have 5 different offices, and as you see here, there are 4 of us are surgeons, 2 of us are periodontists, and a prosthodontist. So I'm very proud to be surrounded actually by 30-somethings. I'm the old man of the group, so to speak, and I've enjoyed the energy of these young folks for sure. I've also enjoyed the fact that we're celebrating now our 30th anniversary at the Institute, where I have been involved with more than 4,300 alumni, all 50 states and 43 countries. So it's been really a pleasure to be and an honor to be an educator and an educator and clinician. So at any rate, with that said, this particular topic is in chapter 5 of the book that I have was published actually last August, and I cover this topic in quite some detail. So those of you interested in reading up more about what I have to say, you can certainly find it in that chapter. Disclosure: none of these images have been altered or manipulated. I think it's real important that I share that with you, and that all my images are from my own cases. I think this is very important. In this day and age of digital technology, we can grow bone, grow soft tissue at the push of a button, and that's not happening here. So our agenda for the talk here is, as you see, we're going to go through each of these topics, starting with some general comments about sinus bone grafting. I got involved in 1989, did my first lateral wall approach, and over the years, I should say now, some 30 plus years, I've been involved with quite a few of these grafts, as we're going to talk about. Historically speaking, Dr. Tatum, Dr. Boyne, Dr. James were the pioneers with this particular lateral wall approach. As you can see, I've performed now more than 1,400 lateral wall approaches, more than 500 crestal approaches over the years. We know from a predictability standpoint that these grafts are predictable, complications are few, but when they hit, we need to know how to deal with them from an infection standpoint. Complications really per se won't really be covering in this particular talk. However, definitely we need to know and appreciate what that's all about, certainly. So let's look at just briefly some anatomy biology with regard to the sinus membrane. I think there's some myths perpetuated with regard to what this membrane is all about. The fact that it actually produces bone and plays a huge role with regard to bone regeneration in the sinus, and the reality that's not true. There are minimal numbers of osteoblasts within the periosteal layer of the schneiderian membrane, and the thickness varies from 0.3 to 0.8 millimeters, which means, in essence, that we can have some super thin membranes. 0.3 of a millimeter is eggshell membrane. Keep that in mind, which is something like this. And when you see this, even looking at it the wrong way, becomes this. That's a full tear, but no worry, as we're going to talk about here a little bit later, there's a membrane repair technique that I've come up with from the early 90s that makes this particular problem go away. So a few comments, again, along the lines of anatomy. The osteometal complex, of course, is very important to appreciate. This is, of course, true as the drainage for our sinus, and must be kept patent. And as you see on this cadaver specimen, the middle meatus, of course, is located right inferior to the middle conch. So if it's patent, as we're seeing here, we have a green light to proceed with our sinus grafting, be it lateral or crestal approaches. But definitely if it's occluded, then we need to look for a solution, which typically would be an ENT evaluation for opening this area up prior to our graft. Now, radiographically, I think it's important that we appreciate that there are different parameters we look at. For sure, the CBCT is a must. I think it should go without saying. There's no question that we need to evaluate the sinus from a CBCT perspective. assessing our anatomy of the sinus and the alveolar ridge in general, the osteometal complex in terms of patency, no question, any septi that might be involved, ruling out pathology. In general, I think the bottom line here is that we must evaluate our cases with this technology to definitely decrease surgical risk and complications. And in this day and age, I think that should really go without saying. So, a few comments regarding the lateral wall two-stage protocol, because these types of cases where we have essentially fully pneumatized sinuses lend themselves, I think, perfectly well to the lateral wall approach. And as you're seeing here, on a fully pneumatized sinus, meaning the residual bone height is maybe 0 to 1 or 2 millimeters or so, the lateral wall is still indicated, at least in my opinion, for a predictable result. We can also use lateral wall for simultaneous implant placement if we have adequate alveolar bone. Again, residual bone height is at least several millimeters to retain these implants and minimize, if not eliminate, any mobility, then that happens as well. Now, that said, we're going to turn now to crestal grafting traditional approaches, I'm going to call it. And there'll be some comments now from an historical perspective before we get into what I've been doing for the past 5 years. Now, before I really get started in this topic, though, I would like to just make a few quick comments regarding the lateral wall approach, and that is that there are definitely indications for one to know how to do lateral wall, in fact, even before one learns how to do crestal approach to the sinus. And I say this with strong conviction because unfortunately there are some folks that are running around the country and even the world that are promoting crestal sinus grafting so hard that they're literally telling the younger folks the following, and that is, don't worry about lateral wall grafting. It's going to go away if it's not really gone already. And because of different technologies, specifically osteodensification, which I will address here shortly, and is at the heart of my protocol that I have followed now for 5 years and resulted in a paradigm shift for me to even explore again crestal approaches. So what I'm saying is that indications for lateral wall would be, for example, very simply, you have a large perforation with your crestal approach. Do you abort or do you continue? That's more of a rhetorical question, but the reality is many times we're going to go right to the lateral wall and go about our business, especially if we've already grafted in that sinus and we found that we've perfed, then another indication for lateral wall. And how about our lateral augmentation of the alveolar ridge? In other words, a horizontal augmentation with simultaneous sinus grafting, another indication for crestal and, I beg your pardon, lateral wall and simultaneous grafting for horizontal augmentation. So what do we mean by traditional sinus grafting? Well, for many years, back in the 70s, Hilt Tatum really began, I believe, was probably one of the first, if not the first individual to utilize the crestal approach. Summers came along in the 90s and repopularized this approach with osteotomes. And then we've had a number of different modifications from bone-added osteotome techniques to what's termed a modified trephine osteotome approach, which, as you can see schematically, looks great, but trying to replicate that, good luck. And our Italian colleagues came up with even a set of quote-unquote atraumatic drills to address this potential approach. And we have on and on a number of different crestal bone impacted trap techniques, etc. And I can go on and on, but the reality is all of these techniques were more or less blind techniques. And as you're seeing here by some quotes directly from some of our colleagues overseas, that membrane perforation really was not even able to be visualized until it was too late, especially if you placed graft material into the sinus via this crestal approach. You can see this quote-unquote anarchic spreading of bone particles within the sinus and failure of the sinus for elevation procedure. So bottom line is not predictable. And if you look again over the years, many different acronyms, as you're seeing here, have been applied to these different approaches. And one of my favorites that I sort of like to make a little bit fun about is this Miambi approach that really was a minimally invasive, I believe, antral membrane balloon elevation that only cost a few $1,000 to get involved, in another $150 per balloon, and only watch it explode in your sinus and out the window. So the so-called pump didn't work so well. And today I don't know that anybody really uses this approach. So what I'm saying is what came along for myself and many, many others globally, as we know today, is this entire paradigm shift utilizing certain specific drills and the concept of osteodensification. And we can certainly give credit to Salah Huwais for coming up with this particular invention. And what it has allowed us to do is take advantage of the biomechanics of bone. Without getting into an entire dissertation, this is a lecture topic that really encompasses hours to give it any real service. But the bottom line is, we know because bone is viscoelastic and has these properties of being able to more or less have plasticity and be able to deform. As a result of that, these drills that have been invented allow us in low density bone, type 3, type 4 bone, D3, D4 only, to use them in a counterclockwise mode and thus be able to densify bone, meaning just spreading the bone laterally. Instead of removing bone, we are moving it. We move it laterally and apically. So the apical element is important for crestal sinus grafting, certainly. So as you're seeing here, there's different laser marks on the drills that, of course, facilitate, as you're going to see in a bit, crestal grafting using the drills. So again, not a lot of detail other than to tell you there are different stages of what, or I should say applications in terms of the protocol. But the bottom line is we get this real-time haptic feedback effect where when we use the burrs in a reverse mode, we get a pushback. So we know where we're at all the time. And this compression wave that is created really allows for the bone, again, to be placed in a, or displaced rather, in an apical mode. And we're densifying this bone as we've talked about. So the bone literally is displaced laterally into the walls of the osteotomy. And again, won't get into a lot of detail except to tell you that if we just compare different drilling techniques, we can get a perfect circle with these drills, whether we use them in a clockwise mode like this or counterclockwise mode where we're impacting the bone. So we have CT studies and histology to verify this. If you're going to read one article on this topic, it would be this one I would recommend for you, because what Salah has done with his cohort, Dr. Meyer, is to really give initial validation to the procedure. And the bottom line is right here. And I'm not going to read this slide. You can look at it and sort of absorb it for what it's worth. But at the end of the day, we're increasing bone mineral density. And very importantly, here on the bottom is we're really creating more of a 3 to 4 times the implant contact versus standard densification. So we're increasing primary stability of our implants. That's what we need to know. So with that said, misclassification we're all familiar with, varying degrees of residual bone height from more than 12 millimeters all the way down to less than 5, 4, 3, 2, 1, more or less. So this residual bone height, measured from the crest of the ridge to the floor of the sinus, this is what it's all about. RBH, acronym for residual bone height. For me, a 5 millimeter number, even 4, some 4s, I will utilize the osteodensification approach or protocol, if you will, for crestal sinus grafting. And below that 4 number, 4 or less, more or less, I will typically go to a lateral wall approach, as we'll see. So again, using these drills in sequential mode, what in essence we're able to do very predictably, and this is the key for me because I can see this membrane, I can visualize it at all times. And that's important because remember, historically, I showed you all those procedures that really didn't do us well because we could perforate and not even know that. Here you can see the membrane. And we're using this particular alloplast called NovaBone. And as you're seeing here with this animation, we can take this NovaBone and literally place it into the osteotomy. And at this point, use our burrs to displace it apically. And just so we understand each other here, this is a specific putty that is a synthetic. Again, it's an alloplast. It's a calcium phosphosilicate. And it is very impressive in terms of its handling ability. Comes in two different sizes, a 0.25 and a 0.5 cc version. And in a nutshell, the delivery is very precise because we're able to deliver it through a very small 3mm cannula, and the density allows for just a normal hydraulic lift of the membrane. And most importantly, we're seeing a radial density, as you see here right off the bat, which is impressive in and of itself, which becomes an opacity later. And just for the record, I was able to express this 0.25 cc carpule of Novabone on a tongue blade and measured. It's approximately 5 millimeters, I beg your pardon, 5 centimeters. So in essence, what we're saying here is that in terms of some guidelines, how to use this, it comes in 0.25, remember, 0.5 carpules. The 0.25 is good for about a 3mm lift, roughly. In other words, a 1/2 site. If we go another few millimeters more, up to 5 or 6, then we need additional material, roughly 0.5. So the rule of thumb is 0.1 cc's per millimeter lift. It's very cost effective. And again, we take intraoperative radiographs, as you're seeing here, very nicely. And as we displace this bone, this putty, if you will, I should say, into the sinus, again, we can see this well-delineated dome that we look for. And of course, taking sequential radiographs, we will know throughout whether or not we have a perforation. Definitely when we place the putty, again, being so radiodense, if we see this configuration, we know that we're confined within the membrane, so we have not perforated. And this is, of course, very valuable information for us, certainly. So looking at a video, we can now begin to see more or less what we're talking about in action, measuring roughly, say, 6 millimeters of residual bone height on this particular single tooth site. And we're just going to go, for sake of time, right to our drilling protocol. So you're going to see we use a series of these drills. There are 12 in the set and apply to any, it's an open platform system, so they apply to any implant type, does not matter. But as we're using them in a counterclockwise mode, at a certain point, typically the 3mm diameter of drill size will actually go through the sinus floor and penetrate into the sinus. And what we then typically do, in this case, this would be a 3/8 diameter implant, I beg your pardon, I believe a 4/6 diameter implant. So we are placing, drilling to 4.3, and then introducing right here. And I just want to stop our video right there. We're introducing the putty. And in doing that, we can actually elevate the membrane through hydraulic pressure alone. But in addition, what we're doing is using that same drill diameter, in this case 4.3, counterclockwise at a lower RPM, typically 100, 150. And we continue to add increments of our putty. And finally, you're seeing the implant being placed into position, and we're suturing, of course, closed. And here's what's important is to see now at the end, we had a 6mm height, remember, ridge. Now that's a 10.5mm diameter, or I should say length implant. We have 2mm apical to the implant apex. So if we started with 6, we end up with 10.5 plus 2. So we have roughly a 6mm increase in height. Now, can I get that all the time predictably? No, I can't. But I can get 3 to 4 very predictably without any problem. And in my last year now, it's been 5 years of using this technique, I would say that the 4, 5 plus number is becoming more realistic as well. But remember, it's a numbers game with the membrane, how thick the membrane is. Remember, 0.3 to 0.6 millimeters. I'm sorry, 0.3 to 0.8 millimeters. 0.3 of a millimeter membrane is super thin. So it's so thin, it's an eggshell membrane. So if that's the case, if we think that we can literally elevate that membrane predictably without perfing, I think we need to reevaluate our own thought processes. So Let's look at this case. Here we have an RBH of barely 3. So in this case, I will use the 0.25 cartridge to elevate at least 3 to 4 millimeters of the membrane. And again, we've expressed it as I shown you earlier. Just the 0.25 cc gives you this amount of volume, so you can have an appreciation for what's in 0.25 cc's, roughly 5 centimeters of length. And then radiographically, this is what we saw sequentially throughout the procedure, ending with a 6 millimeter length implant. So in essence, we gained 3, actually gained 4 to 5 millimeters of height, but placed a 6, so could potentially place even a 7.5 millimeter shorty implant, so to speak. So we started with this, and we have that predictably. Now, could we have gone lateral and increased this length dramatically? Sure. But keep in mind, the minimally invasiveness of this protocol is impressive. And that's important, of course, for all of us to know, and certainly for our patients. And I think that's really, really important. So let me just go back to that for a second and appreciate, again, this volume of material for a 1-tooth site, okay, will give you about 3 to 4 millimeters of height. And as you're seeing here, we got at least that. And again, this length could have been potentially a bit longer. So a few other examples. Let's look at this particular case where we need to place 2 implants. And there are times where this will happen and we'll need to elevate that membrane crestally, yes. And once again, we can communicate through these osteotomies from one site to the next as need be. And there is, again, the alloplast being introduced into the osteotomy. And you have your choice at this point to, which I typically will do, as I've shown you earlier, is take a small condenser and apically reposition that material and then place my drill, which is the last diameter drill before placing the implant. That is the one that we'll use to introduce the graft superiorly and displace it apically into the sinus, beyond the sinus floor. So we introduce that graft at roughly 150 RPM. And here's a 3-month follow-up. And we can appreciate nicely in a 3-year follow-up what we have at the end of that time. So moving along, if we look at this particular case, we have a molar that has issues. So what we're looking at in essence here is to decoronate this tooth and drill through the root, which we do routinely. Many of us have done this now for a number of years. And in these cases, I would recommend you use a set of older drills so you don't ruin your newer ones, because going through, of course, enamel dentin will take its toll on your drills. But for precision implant placement, it's not a bad way to go to utilize this protocol. And in so doing, I think what's impressive is that we're able to see quite nicely the membrane showing up, of course. And as we remove our roots and we continue to increase the diameter of our drill, then we're able to very nicely visualize the membrane as you're seeing here. And I think this is important, because if we can't see the membrane, then we really are going to be involved with a blind procedure. And that's what really gave me fits in years past, even attempting any of the, utilizing any of the protocols that were available with regard to crestal sinus grafting. So quite honestly, for me, it was more or less not doing it. So virtually all my cases up until 5 years ago were lateral wall, regardless of the residual bone height present. So keep in mind now, with the paradigm shift that occurred with the osteodensification protocol, allowed us very nicely to use these sets of drills to elevate the membrane predictably. And as I've mentioned, with regard to the putty, that was really a big plus for me personally, because I've toyed with different allografts, which certainly can work well. But the bottom line is, from a delivery standpoint, utilizing the NovaBone for me was just an absolute natural thing to do. And I've not looked back now during these past 5 years of this protocol. So the putty again lends itself very nicely to placing it with the nozzle within that 3 millimeter cannula within the confines of your osteotomy. And then of course introducing it further apically with the counterclockwise rotation of the drills. So makes all the sense. And then these immediate extraction sites, certainly we can take advantage of this protocol as well. And we can mix, for that matter, the alloplast, as you're seeing here, the NovaBone with mineralized allograft, and then graft in the defect area, as you're seeing here. And then ultimately a 4-year follow-up. Again, predictable. This is what it's all about for all of us. If we can't perform all of our procedures in a predictable mode, I'm just going to tell you that we're kidding ourselves. Not just emotionally and psychologically is it demanding for us and will take its toll on us, but from an economic perspective and even a medical legal perspective could be very problematic. So it is important that we bat in the high 90 percentile with everything we're doing. Carl Misch talked about that many, many years ago. So important that we appreciate predictability for all the items that we do, the procedures that we do. You would think that it should go without saying, but doesn't always, especially to our younger clinicians. So now, moving along with a few more cases to give you examples of, again, the protocol that I have followed now for these years. We have a residual bone height of approximately 5 to 6 millimeters, for example. Our goal should be placing, say, a 10 to 11 millimeter height implant. Why not? We certainly can. And again, using the drills in a very sequential mode. Remember, counterclockwise is used in low density bone, i.e. quality 3, quality 4, type 3, type 4. When we encounter type 1 and type 2 bone, we can still use these drills, but in a clockwise mode. That's the key. So important that we appreciate the precisionness of the drills. I think that's critical because, again, for me personally, it's created a complete paradigm shift for me, both in my clinical practice and at the Institute in teaching the protocol. So we're able to, again, introduce the NovaBone as you're seeing here. And once you suction this area, we're able to see the membrane quite dramatically and appreciate that and verify, I should say, that the membrane is intact, not perfed. If it's perforated, then we have some options on what we can do. A small perforation is not so bad. We can place a small amount of collagen and continue our grafting and implant placement for that matter. Depending on the RBH that we have, there are times where we can stop. If we have an RBH even at 6 to begin with, we can place a 6 millimeter length implant. Or if it's 7 to 8, we can place a 7.5 millimeter length implant for that matter, without even worrying about a membrane exposure. Any amount, a millimeter or so of the apex of an implant through a sinus membrane is of no consequence. Now, I will tell you in the 80s and 90s, many folks talked about all sorts of nasty things happening, including even not just over infection, but cancers and Lord knows what else. So that's certainly been disproven over the years, and I certainly have a number of cases over my 30 plus years of doing these sinus grafts where implants are definitely placed, in through the sinus membrane, at least a millimeter or 2, not the end of the world. So again, there's our NovaBone being placed into the osteotomy. We're condensing it very lightly and then utilizing, again, the drill, the last diameter drill prior to implant placement into the site. And important that you appreciate what osteodensification can do for low density bone. We're densifying the bone, therefore increasing the overall bulk of bone. So one does not need to under prepare the osteotomy. I think this is very important because we can get insertion torques that are significantly high, 70, 80, 90, which in densified bone is not such a good idea because blood supply here is compromised to a degree. And if we're squeezing literally an implant into an osteotomy that's been undersized in densified bone, meaning in a densified osteotomy, then what can happen, and I witnessed this twice in my early use of the drills without knowing exactly what I was doing, getting 90, 100 Newton centimeter torques. Again, in native bone, not a big deal, but in densified bone can be problematic because we can get necrosis of the surrounding bone, and hence the implant fails. Now, just not so much a tutorial, but just quickly using here PTFE suture I've used now for a number of years, large FS2 needle. My incision design for these Crestal cases is always more or less an envelope flap, meaning mid-crestal with a sulcular incision, including the papilla of the adjacent tooth on either side. So therefore, when I'm suturing, I'd use just a sling suture to come through and reapproximate that papilla. And then on the in the crest itself, we'll use sometimes these little rotational flaps, these Palachi flaps, and use a external vertical mattress approach, as you're seeing here, and tying this down very nicely. So the key again is to get good primary closure, which we do typically, and in this case using a small Nesbit for this patient. So this was a sequence of events for this individual. And now looking at still a little different case where we've got an RVH of about 5 millimeters, and we have again back-to-back sites. What's interesting is to be able to connect the membrane elevation in this interseptal bone area, and we can do that very predictably. Now, just a word of, or I should say a comment regarding folks that again who are saying that no question we can work with a 1 millimeter RBH all day long and predictably get crestal elevation, even place an implant at the same time, et cetera, et cetera. I'm going to caution you about that because to show 10 of those in a row would be one thing. Don't know that anybody's indicated that or done any studies to that effect. In other words, it's about predictability. We can show you an N of 1 or 2 on almost anything we do, and that doesn't tell us too much. And I'm not trying to be a smart butt here. It's just that the reality is when this membrane, remember, is 0.3 millimeters thin, there's no way in heaven we're going to elevate that predictably without a perforation, and in most cases, a complete perf. So when that happens and you have a millimeter or 2 of RBH, I don't think you have any choice but to go lateral. So once again, a big plug for learning how to do a lateral wall approach before you learn how to do crestal sinus grafting. I think it's really important to drive that point home. So here we're placing 7.5 millimeter length implant. Nothing wrong with these length implants. Esposito and others have done some great studies over the years. My good friend Gioacchino Canizzaro from Italy has also demonstrated very nicely with some long-term studies that the so-called short implants work extremely well, meaning 6, 7 millimeter implants, even 5s, even 4s in some cases. The shortest implant I'm comfortable with using is a 6.0 length. At any rate, using this crestal approach, we can take advantage of increasing that particular membrane, in other words, elevating that membrane at least 3 to 4 millimeters very predictably and allowing for placement of these implants. Now, cases like this, a little more extreme, where we've got, you can see roots more or less approximating the sinus floor, of course, just a small amount of interseptal bone, and inevitably we will have a perf, as you're seeing here. We can place some collagen and then continue to graft with NovaBone and mineralized allograft in this case, plus a membrane. We don't have to play hero here. In other words, what I'm saying is, quite honestly, there's no reason to think that we are obligated to place an implant, elevate the membrane continuously, etc. Makes no sense. We can, in essence, do a socket graft here and come back at 4 months and go about a nice crestal approach, which will give us an excellent end result. So we don't, again, have to play hero. So in closing, I'll share with you this particular video that, let me just stop our video here. You're seeing an RBH of maybe anywhere from, say, 3 to 5 millimeters barely. And again, many of our cases are like this, where they're slanted. We don't have just a complete horizontal to the floor, to Frankfurt, say, in other words, level with the floor, not happening. There can be a nice tilt like this. So again, do we want to go lateral? Do we want to go crestal? Well, my vote is we'd like to go crestal whenever we can. Who wouldn't want a minimally invasive procedure done on them versus a more aggressive lateral approach? I mean, I'm in. Why not? If it's predictable, especially. So here we are, starting with a pilot burr. And by the way, if you go to the Versa website, I've got nothing to gain by promoting that particular technology, other than the satisfaction of knowing that that is the protocol that is so predictable to utilize for crestal sinus grafting. And I would have the satisfaction of knowing that I'm passing on some useful information if you're not familiar with this particular protocol. So using our pilot burr to start, and again, you want to know the specifics of this protocol, you can go to the website that Versa has, and they've got a lot of good animations and videos to look at. So here we are going clockwise and then counterclockwise, depending on our bone density. So progressing from the 2 millimeter to the 3 millimeter drill, again, counterclockwise in this relatively low density bone. Once we encounter a stop, our drill can't really go much more in a counterclockwise mode, then we can shift to clockwise. And then we're into extraction drilling, which is fine. But the bottom line is the whole goal there is to get to that sinus floor and just barely penetrate through the floor of the sinus. And we're taking, of course, intraoperative radiographs, as we showed you earlier, verifying position of the drill. And recall that the graft, the actual putty, the NovaBone putty, will be placed with that last drill diameter prior to implant placement. So there's a 3.3 drill, and we're verifying where that drill is intraoperatively. We're now introducing the NovaBone, and you can see we're condensing it just gently, and in goes that same drill diameter, which is the 3.3, the last drill we're using prior to implant placement. Anywhere from 100 to 150 RPMs, counterclockwise, no irrigation. And again, more putties introduced. Remember, 0.25 cc's is approximately what we use for a 3 millimeter to 4 millimeter height increase. Again, additional placement of the graft back with the drill. So we're back and forth. And again, we're taking radiographs, verifying with the drill that we have that dome shape that we want, indicating no perforations. And now we're placing the implant, and you see here a 20 Newton centimeter torque to begin with. We're at 25, we're at 30. And now using our torque wrench, we're seeing that we will probably be at 50 plus, there's 60 Newton centimeters. And again, sequentially, there's the radiographs, as you're seeing here. So again, predictable technique, predictable protocol to utilize for crestal sinus grafting. So in summary, we can look at a number of important points here. Understanding anatomy and biology of our sinus. We didn't do really justice. There's so much information here that we could spend several hours on, certainly. But the importance of knowing, again, how to perform the lateral wall approach before we learn crestal. Clinical significance of osseodensification, yes. Understanding bone biology in general with crestal sinus grafting. And knowing our limitations, of course, but utilizing the protocol that encompasses the placement of this alloplast. I think it's really important, and appreciate that alloplast, the NovaBone over time will literally become bone. So that's the beauty of knowing that it will turn over, and that most impressively, it handles so well, it's cost effective. And for me personally, it's made all the difference with regard to this protocol of using the Versa drills, the osseodensification drills for for crestal sinus grafting. So with that said, we at the Institute for all these years now been able to incorporate so many protocols within our continuum. And as you're seeing here, the theme of our continuum is alveolar ridge strategies, single tooth to full arch reconstruction that encompasses these 4 different courses. They involve, of course, lecture discussion, live surgery, hands-on training, and complications definitely play a big role in terms of content of each of these courses. But specifically for what I've just covered with you briefly during our time together here, you can certainly be able to take advantage of in way more detail by attending one of our sinus graft courses here at the Institute in Trinity, Florida. The course we'll be offering next year is just one, and that is in March, as you see here. But those of you that obviously can never come to our institute that are located throughout the country, throughout the world, actually, can go online, because over these months I've been able to literally put together the entire course online for sinus grafting for implant reconstruction, part of our PICOS Online Masterclass series. As you see here, there's 16 modules that are composed of 25 credit hours and over more than 1,500 slides and 50 plus videos. So all of this together, and we're able to offer this to you so that you don't have to physically be here. So I think it's a very unique course, to say the least. 25 hours is a lot of material, lots of videos, lots of slides. And this includes webinars that we give throughout the year, typically 3 of them for our attendees that have signed up for the course. So with that said, I think important that we don't lose sight of our family with all of the things that we do. You know, I certainly have passion for my work, as I know so many of you as well do, but we can't, of course, overlook our family. And for myself and my wife, I will tell you, these last few years, we've been blessed with 2 wonderful grandchildren. Our daughter has blessed us with a beautiful granddaughter, Ella Sophia, who's now just over 2.5 years old. And little Andrew, the newer addition, he's 8 months old now, and little rascal weighs 23 pounds. Little Ella's 29 pounds, so she's only 6 pounds ahead of her brother, but she's 2 years older than him. So this is amazing what milk can do, only milk for a little guy. But at any rate, enjoying the grandkids. And with that said, I would like to thank all of you who have attended this particular webinar live now. And we'll turn things over to some questions, which I can see we've got quite a few of them. And I'll just, no particular order, start addressing them. We've got about, I'm guessing here, about 15 minutes of time left. So this will work out well. And excuse me. Can we do all crestal sinus grafts with DensaVerse only? Well, if I'm understanding that question well enough, the answer is yes. You don't need other drills or other protocols that can be followed, certainly, for crestal sinus grafting. And as I've shared with you historically, some folks continue to use osteotomes and other different instrumentation. But for me personally, I like to keep things rather simple and, most importantly, based on solid science. So the answer is yes to that, yes. Now, I'm a general dentist who is fairly recent grad, but there's a difference in using synthetic bone, or is there a difference in using synthetic bone like Nova Putty versus allograft? It's a very good question. Personally, I'm not a big fan of alloplasts in general. I can tell you the Nova Bone is the only one I've used in years. I played with a few of the alloplasts early in my career in the early 80s, but abandoned that rather quickly. So I think there's something to be said for this particular alloplast, only because I've seen what it does over time. And again, I only trust what is happening for me personally with my own cases, and therefore will teach accordingly rather than be more or less talking about things anecdotally. But can an allograft be used? Absolutely, yes. And A number of clinicians prefer to use even mineralized allografts or some demineralized grafts, etc., as part of the protocol. Certainly, that is very true. So no question. How do you repair membrane perfs, if any? Thanks. Well, I know I only briefly shared with you the some concepts verbally, but I've got an entire lecture, in fact, a good part of my sinus graft course that addresses literally how we handle complete perfs and large perforations of the sinus. I will tell you that in the more than 1,400 lateral wall approach, rather grafts I've done in my 30 plus years of doing these cases, I have not aborted one case, not one single case, regardless of the perforation, whether it's large, complete, doesn't matter, because the membrane technique that I have developed in the early 90s and continue to use and lecture about really encompasses the use of a cross-linked bovine collagen, type 1 bovine cross-linked membrane that resorbs in roughly several months, but most importantly has structural integrity to maintain itself within a sinus, so that this picture, there is no membrane. It's completely perfed. So we elevate the remnants of that membrane away from the bony walls and then apply the membrane. I typically will round the corners of a 30 by 40 millimeter membrane and cut them about 7-8 millimeters to allow for the ends to fold on themselves, and place that membrane within the sinus with external fixation when I use the flanges of that membrane externally, typically 2 or 3 tacks. And occasionally I will place a tack within the sinus as well to confine that membrane. If you could picture in your mind's eye the membrane that will then drape on the anterior, posterior, medial, and lateral wall of the sinus, but yet not going to the floor of the sinus, meaning we leave a circumferential area of bone about 7 millimeters or so from the floor, so that in essence the bony walls, of course, are going to produce bone and help our graft to turn over, not the membrane. That is a complete myth. And in my lecture and talk on the 12 common myths and realities of sinus grafting, that is a huge myth that I like to explode, because there are folks that still talk about the osteogenic capacity of the Schneiderian membrane, and the reality is it's zilch. It's in percent contribution, probably 0.000001. So moving along, let's see here. What is the reason conceptually that counterclockwise needs to be used with softer bone and clockwise with harder bone? Well, I tell you what, I wish I had figured that out myself, because that would have been great to be the inventor and say that I figured that out, but I did not. And again, I give credit to Dr. Huwace, who did come up with this concept. And the concept is such that if you can picture the flutes and the rakes, what are termed rakes, in the lands of a typical drill, the way they're designed for virtually every implant company, this comes from the industrial sector, meaning how do we basically use a drill, for example, into dirt or bone, wood or aluminum, steel, always in a clockwise mode, and it's termed extraction drilling. So when you remove the drill from one of these materials, you're seeing that material in the drill itself, right, within the flutes. Well, the design of these specific 12 drills is such that we can still go clockwise, absolutely, in type 1 and type 2 bone, because we're not going to densify bone there. It's too dense already. We will just extract the bone, creating the osteotomy. However, when we have low density bone, i.e. posterior maxilla in particular, we can use these same drills in such a way counterclockwise that it pushes, literally pushes, the way they're designed, again, the flutes in particular, and the lands and the rakes, they push the bone centripetally, meaning outside the diameter of the drill, in other words, into the bony walls. So within the trabecular spaces, you get the bone displaced, and it's displaced apically, like a ceiling fan. So it's so neat that this concept allows us to use it specifically in conjunction with our crestal sinus grafting. So hence we have a predictable result, and again, made all the difference for me in terms of being able to now revisit, and for these 5 years, crestal sinus grafting, no doubt. And we give credit where credit is due to Salah Hawaii, certainly, and to Ziv Mazer, who's been teaching this now for a number of years, and together with Salah, really teamed up and created a nice 1-2 punch with regard to the crestal approach that really has paved the path and paved the way for everyone else really to kind of follow suit and utilize these protocols in a very predictable mode once again. So can I review the direction of rotation for the densification burr when approaching the membrane? It's not so much the direction. Well, it is counterclockwise, yes. So when we go through the bony floor, typically the recommendation from the inventor himself is that the 3 millimeter diameter number, we will penetrate the bony floor. And you can feel most all the time the denseness of that floor, because you'll hit a stop. You just feel that that drill's not advancing counterclockwise. It's not going anywhere. So you've got to be patient. And at times I'll even go a little bit clockwise just to get through that bony floor and then stop and go counterclockwise, because the ends of these drills are blunt, which lend themselves beautifully to elevating the membrane without perfing if you're super careful. Now again, if you have a super thin membrane, 0.3 tenths or even less, you may well perf. I don't care how careful you are or whatever, because I could swear on 10 Bibles that I'm, being so careful and I'm not going to perf this case, and inevitably I do. So it will happen, but the more you do of these cases, the less it's going to happen, but it will happen, because again, it's all about anatomy, not so much, who we are clinically and our experience level. I find it hard to pop through the membrane with Versa. Want to make sure I don't use my normal implant drills when trying to breach through. Any tips? Yeah. Well, again, I think when you're referring to pop through the membrane, meaning popping through the bony floor. And what I just said is important, again, to reiterate, and that is you will more often than not feel a stop. And that is dimensionally, depending on how you go back to your CBCT, measure the RBH, that residual bone height, right off the bat. Let's say it's 5 millimeters. We're going to stop our drills at 4 and verify that intraoperatively to make sure that we're where we need to be, taking radiographs, etc. And then as we approach the bony floor of the sinus, that again, with the 3 millimeter drill, you'll feel a stop. And then with very careful, meticulous pressure on the handpiece and then turn the drill, you'll be able to just very penetrate through that wall, through the floor in essence. And it's important that we don't penetrate more than 2 to even 3 millimeters max with any of these drills. That's important. And then as we introduce the graft, in this case the NovaBone, we again are very careful to lower the RPMs, because typically we're between 12 and 1500 easily. I go even greater for normal drilling. However, we slow it down to about 150, no irrigation, to propel the graft into the sinus itself. Now, a question regarding osteomial complex, if it's blocked, are we suggesting that we abort the procedure or not even begin the procedure when doing lateral wall approach? Well, yeah, exactly. I mean, if the LMC is occluded, that's part of our CBCT workup. We're going to look at the axial coronal and certainly sagittal cuts of our sinus, but the the coronal, the frontal cut will give us a beautiful view of the OMC. And as you pan into and out of your field of view, you'll be able to see whether or not it's patent. If it's occluded, that patient is off typically to my ENT colleague to open it up, especially if there's pathology that's involved with that occlusion, then all the more our ENT colleagues will typically perform what's called a FESS, F-E-S-S procedure. That is an acronym for a functional endoscopic sinus surgery approach. That means it's very minimally invasive through the nose, and they can sort of almost like a little rotor, they can open things up and clean out the sinus. So that is typically what we're looking at. Antibiotic of choice for our cases, typically I'm recommending Augmentin. Amoxicillin by itself for any of our sinus grafts really is of no benefit. Augmentin is important. That clavulanic acid makes a difference, and that's 875 BID, starting that a day before surgery and continuing it for another 5 days beyond. So that's the antibiotic regimen. Let's see, any predictable preoperative way to tell what kind of membrane thickness you're dealing with? That's a good question. Yes, there is. I mean, our cone beam CT will indicate thickness of membrane only when there's some pathology, meaning there's some thickness of the membrane due to perhaps a sinusitis or maybe just allergies or whatever the case may be. But we're talking only a few millimeters or so, we can see that thickness. And I think what's important to note is that when we have pathology in general, for example, mucus retention, cysts, polyps, or thickened sinus membranes, the rule of thumb that I recommend that you follow is the following, and that is, depending on size of the pathology and location, those are the 2 key parameters. Depending on those 2 parameters, that will dictate whether or not that pathology needs to be removed at time of surgery, or leaving it be and going about the grafting procedure, be it crestal or even lateral wall. And I say that because it's all about what? That particular pathology obtunding, i.e. blocking the osteometal complex. So if you can picture in your mind's eye and looking at your scan where the pathology is, the extent of it, location and size, when you displace that membrane, will that displacement result in the pathology being literally moved apically and potentially medially into the osteometal complex? If that's happening, then it should be removed. And that's kind of the simple rule of thumb to follow. Yeah. A question regarding, is this extraction? Oh, no, I'm sorry. If the membrane is small, if a membrane in parentheses small perforation occurs, can we continue ossification and placing an implant or preserving the socket after collagen sponge and delay the implant? Okay, so I think I sort of answered this before, but either way, if a perf is small, what's small? A millimeter or so, not such a big deal. Depends on the RBH that you have to begin with. Because let's say we have 5, and our goal is to get to 7 or 8 or 9. That's great. But if we get a small perf, and we're nervous about that, if it's a single tooth situation, we may well be able to get along with, and especially if it's even a larger perf, a 6 millimeter implant and call it a day without any graft, period. If one wants a longer implant and there's a complete perf, then my vote would be go lateral wall. Takes no time, depending on your skill sets and the experience you have. We can do a lateral approach for a single tooth case very quickly and visualize directly what's going on. Place a long implant, say 12 millimeters, and a very substantial graft, and that's all done very quickly. So that would be the best approach that I would use then, sure. So something to be said for that. And again, seems to be a question here regarding when would I go lateral versus crestal? Well, again, rule of thumb, everybody has a different protocol. I think what is important here is to know that you need both procedures to be mastered, and I mean mastered. If you're looking at doing crestal only, and you're being swayed by those folks who are definitely in the minority, saying that that's all you need to know, I'm going to tell you that based on my experience over these 30 plus years, I will flat out say that that's not wise information, because you're going to get yourself into some problems. You will need to do lateral approaches at some point, I promise you, be it pathology dictates that, or that lateral augmentation of the ridge, and or complete perfs of your crestal approach. So there are a number of reasons that that I think mandate that we learn how to do lateral first and then crestal in that order. So with that said, it looks like our time is up. So I think I've answered virtually all the questions. There are a few more, it looks like, but at any rate, I'm more than happy to accommodate those questions if anyone is interested in emailing me, I'll be more than happy to accommodate your questions. So with that said, I thank you for your time and look forward to meeting many of you down the road as this entire pandemic will hopefully get behind us sooner than later. I look forward to the socialization and what's so important within our profession that we have such a wonderful field that we're all in, but it's all about the people. And that's what I think I miss the most. And I know all of you feel the same way, I'm sure of that. So again, I thank you for your time and wish all of you all the best.
Thank you for attending this webinar. Due to the high traffic, we are staggering access to the CE exam to improve your user experience. We will be emailing you a link to your CE exam. Please allow 2 hours to receive the link. If you do not receive the email, you can access your CE exam at any time in the future following the 2-hour period. Simply log in, click CE in Progress or My Account, click on the webinar title, and take the CE exam. Thank you, and have a nice evening.